So let's discuss a bit about acute complications of COVID-19. These are my disclosures. So in this almost 2 years of the pandemic, we learned about the prognosis and evolution of patients with COVID-19. We learned that after an incubation period of about 5 days, there are the onset of symptoms. And some patients, when they turn from the first to the second week, tend to develop severe or critical illness. Severe illness tend to develop in about 14% of symptomatic patients and critical illness in 5% of symptomatic patients. Most of these insights initially came from this cohort study from China published in The Lancet, where they compare survivors and non-survivors of COVID-19. And this cohort demonstrated that in non-survivors, usually sepsis and ARDS start on the second week, and further on, some patients develop other important complications that we are discussing today, such as acute cardiac injury, acute kidney injury, secondary infection, neurological complications, and some patients also will unfortunately die because of complications of COVID-19. When comparing survivors and non-survivors, the authors of this cohort study found a typical cytokine storm syndrome. So they demonstrated that patients with elevation of the dimers, elevations of IL-6 level, elevation of cardiac troponin, and other markers like ferritin, when these markers were elevated, mortality raised steadily in correspondence of the elevation of all these biomarkers. So now, after these 2 years, we tend to didactically divide 3 COVID-19 stages. So stage 1 is usually the early infection, when we have a viral response phase, and then when it turns from the first to the second week, usually start stage 2, which we call the pulmonary phase, and where some patients develop a host inflammatory response. And unfortunately, some of these patients, as we've seen, 14% tends to develop severe infection and about 5% tends to develop critical illness. Most of this critical illness and manifestations, such as ARDS, shock, cardiac failure, and renal failure, are related to the hyperinflammatory state. So we now know that the key difference between patients with mild and severe COVID-19 are related to the inflammatory phase. We also know by dividing the patients in these 3 stages how to treat them. We know that early on, when we have virus shedding, patients will need antiviral drugs, specifically against COVID-19. We know that for patients who are hospitalized, we need to use immunomodulators and steroids. But today, I'm not talking about the clinical trials of therapy, but this didactic division of different stages, once again, will help us to tailor and to inform therapeutic decisions. We also know that patients with comorbidities are the ones who tend to have higher mortality. For example, one important comorbidity is the presence of cardiovascular disease. So usually patients with cardiovascular disease as compared to patients without cardiovascular disease in this large observational study, also published early on from China, have had a 5-fold increase in mortality at 30 days compared to patients without these risk factors. And we now know that besides cardiovascular disease, other factors like old age, like COPD, like type 2 diabetes and obesity, and I will include here also hypertension, but patients with sickle cell disease, patients with CKD, and of course, patients who are immunocompromised and patients with cancer are the ones who tend to develop more frequently cases of severe COVID-19. And there are several potential acute complications of COVID-19. For sure, the most important and most frequent one is the respiratory complications, including, for example, pneumonia and, in some patients, ARDS. But we also learned that some patients will develop cardiac complications, some patients will develop neurological complications, and we should also be aware of systemic complication, including acute kidney injury. And we already discussed it very briefly, the cytokine storm. The cytokine storm is very complex. I don't have time today to go over all the details, but that's an important complication. But also, of course, secondary infection is part of it. And there are other complications as well. So in terms of respiratory complications, ARDS is the major complication for sure for the 14% of patients who develop severe disease and can manifest shortly after the onset of dyspnea, usually starting between the 9th and the 10th days. In a study, an observational initial study of about 140 patients, for example, ARDS developing 20% a median of 8 days after the onset of symptom, and about 12% mechanical ventilation was implemented. This finding was replicated in major cohort studies from the US, from Brazil, from China, and also from Italy. But besides ARDS, some patients also develop thromboembolic complication, and we also need to think about pulmonary embolism in some patients, and this obviously drive and inform therapeutic strategies for these severe patients. There's several ways in which COVID can also create and cause, I would say, cardiovascular complications. Of course, there is a direct relation between the hyperinflammatory state, inflammation, and myocardial damage and myocarditis, but the cytokine storm has also been associated with plaque instability and rupture, with thrombotic events, with microvascular dysfunction, with heart failure, with arrhythmias, and with other venous thromboembolic events. In fact, major arterial venous thromboembolism in patients with COVID-19 at 30 days from diagnosis were admitted to ICU have been observed in about 35% of patients, and of course, is much less frequent in patients which are hospitalized but don't need critical support. Major cardiovascular events tend to occur in hospitalized patients in about 6% of them at 30 days, and is, of course, much more frequent in critically ill patients, happening about 46% of these patients. And we already discussed that despite thromboprophylaxis, about 27% of patients admitted to the ICU will develop symptomatic venous thromboembolism. Interestingly enough, full dose anticoagulation or anticoagulation therapeutic dose in critically ill patients was associated with increased bleeding and was not associated with decreased risk of organ failure or mortality. And the opposite was observed in patients who were hospitalized but not critically ill. But once again, I'm not discussing therapeutics today and clinical trials. There are several reasons for this increased risk of thromboembolic events, which are both arterial and venous. And of course, risk factors of critical illness, such as being bedridden, diarrhea, sepsis, and of course, if patients have comorbidities like malignancy, like COPD, like heart failure, they increase the risk of thrombotic events. But we also need to remember that the inflammatory response to the cytokine storm, and once again, I'm talking about cytokine storm in a very generic way. This is much more complex than that. It will require a specific session to discuss the pathophysiology. But let's say this in a generic form of cytokine storm here is associated with increased thrombotic events. We also need to think about neurological complications. For example, encephalopathy in the beginning of the COVID pandemic was commonly observed among critically ill patients, of course, much less frequent in non-critically ill patients. But of course, in these critically ill patients, initially in patients who were hospitalized, it was reported in about 1/3 of these patients. We also need to think about stroke because of the thrombotic environment, but also less frequent manifestations like ataxia, seizures, or movement disorders. Of course, they can happen, but they are much less frequent than encephalopathy and other neurological manifestations. Another important fact that's been observed, not only in acute COVID, but also in long-term COVID-19, are the neuropsychiatric manifestations. And of course, they have a very close relationship with age. So for example, in elderly patients, in patients over 70 years with COVID-19, neuropsychiatry manifestations can occur in about 30% of them, and stroke has been observed in almost 35% of them. So we need to be aware of neurological complications in acute COVID-19, but much more importantly, also we're learning about the neurological and psychiatry manifestations of COVID-19 in patients with long COVID. Another important type of complication of COVID-19, acute complication, has to do with acute kidney injury and acute renal failure. This being related to both direct viral effects in the kidney, but of course there are several indirect effects that are well known in sepsis, that are well known in critical illness, like hypovolemia, like acute tubular injury, like of course, it guards a very close relationship with the fluid management, and of course, acute kidney injury, it's common among patients who are critically ill. And of course, coagulopathy and inflammation has also an effect in causing acute kidney injury that is especially common among patients which are critically ill. A recent cohort study, a very large one, published in The Lancet in July, I think it's the best publication so far in terms of characterizing these complications of patients who are hospitalized with COVID-19. The authors enrolled about 80,000 patients, from which about 36 reported at least one in-hospital complication. So we see that all the complications that we discussed can be quite common. Of course, this happens both in male and in female patients with COVID-19. And of course, it's more common in elderly patients, and is, of course, more common in patients with 2 or more comorbidities, the comorbidities that we just discussed. And of course, the more frequent the complications and the more frequent and the more prevalent the comorbidities, of course, it has a profound impact on survival. So patients with multiple comorbidities and patients who have 2 or more complications had a much higher mortality rate as expected than patients who are younger and who do not have comorbidities or who do not have complications. Of course, acute complications can increase the risk of all-cause mortality and critical admissions. For example, the most important complication associated with mortality was the respiratory complications, ARDS, followed by the cardiovascular complications. And of course, the respiratory complications, especially, of course, pneumonia and ARDS, are associated with a 12-fold increase in the risk of critical care admission, but we must be aware that all the other complications that we discussed, the renal, neurological, and cardiovascular complications, for example, they all increase the risk of mortality independently of other complications and of comorbidities, and they all increase the risk of critical care admissions. And this is true in both male and female patients. So in patients with no comorbidities, we can see that the risk of complications is about 38%, but when we look at patients with 2 or more comorbidities, that can increase in up to more than half of patients in 55%. And this is true, once again, both in male and in female patients. And of course, mortality, as we just seen in male and female patients, is much increased when we compare patients with 2 or more comorbidities compared to patients without comorbidities. So the more frequent the comorbidities, the larger the number of complications, as one would expect, the higher the mortality. And once again, understanding the disease progression, and we learned about it in the past 2 years, once again, will help us to tailor therapies, will help us to inform the design of clinical trials, and will help us to guide the best therapies that we have. Nowadays, the key therapies that we are using are the antiviral therapies initially, and of course, we now have the antibody, the monoclonal antibodies therapies for using in outpatients, the immunomodulators and the steroids in patients who are hospitalized, especially in the inflammatory phase. Full dose anticoagulation is still being questioned. We have some positive trials or other negative trials. Nevertheless, in patients with moderate disease, it may also be helpful. Thanks very much for your attention.